All right, let's get started. And then if some folks jump on a little bit late, that's all right. Thanks everybody for joining us. I'm Rachel Brown with the Colorado Department of Public Health and Environment. I'm covering for Kate Cohen as the Shared Risk and Protective Factors Peer-to-Peer Network Lead. I'd love it if you all could introduce yourselves in the chat. Just type in your name, your pronouns if you want to share them, and where you're joining us from, so we know who all is here today. Today we have a presentation from Sasha Mintz, who's the Child Fatality Prevention System epidemiologist here at CDPHE, and she's going to be talking about framing data using an equity lens. Sasha will have some time for questions throughout the presentation, and then also at the end, you can feel free to type any questions into the chat at any time. And let's get started.
Okay, cool. Thanks, Rachel. Can everyone hear me? Okay, so as Rachel said, my name is Sasha Mintz, and I am the epidemiologist for our Child Fatality Prevention System here in Colorado. And I'm going to be presenting today about the importance of sharing disparity data through an equity lens. It will also become clear that the systemic inequities that people experience are shared risk factors and have impacts across multiple health outcomes. So given my area of work, I'll be focusing a lot on the outcome of child deaths due to injury and violence, but know that a lot of what I'm going to be talking about can be applied to other areas and outcomes, which I wanted to make sure to say because I know that a lot of folks on the line are working on different outcomes. So just keep that in mind, that anything that I share today can be applied to your area of work. What I'm going to be talking about today is pretty heavy content, so please take care of yourself throughout the webinar. But I also want to start with sort of a lighthearted poll that I know we can all relate to right now. So hand on your heart, are you wearing pajamas right now? Okay, still a few votes trickling in. I love the chat too. Okay, so I'm gonna end the polling and share out. It was pretty evenly mixed, but the majority, 33%, said never. So that is pretty wild because I'm definitely wearing leggings and a shirt that can basically be pajamas. So thank you all. Stop sharing that. Okay. Here's the outline for the rest of today's webinar. And since there may be partners on the line who are not familiar with the Child Fatality Prevention System, I'm going to start by quickly reviewing what the Child Fatality Prevention System is and how we're structured. This will really help understand why it's important from a prevention perspective that we thoughtfully frame our data. I'll then speak about the 3 disparity areas that we focus on as a system, reviewing inequities related to geography, race, ethnicity, sexual orientation, and gender identity that contribute to child deaths. And as Rachel said, we'll have plenty of time throughout the presentation for questions and also time at the end. I only probably plan to talk for about 35 minutes, and the rest of the time is open for questions and discussion about whatever I share or whatever comes to mind for you all. So feel free to unmute yourself or enter your questions into the chat box. I might not do the best at monitoring the chat box. So Rachel, if any questions come in there, will you help me out? But definitely please ask any and all questions that come up. And so as I mentioned, I'll start with what the Child Fatality Prevention System is, followed by a bit of framing. So the Child Fatality Prevention System, or CFPS as I'll refer to it throughout the rest of the presentation, is our statewide public health process to prevent child deaths in Colorado. In this figure, you can see that CFPS consists of 3 arms and many different people. I'm gonna stop because can you hear that lawnmower outside? Give me a second.
No,
Okay.
I can't hear it.
Give me a second to close my window. Apologies. So the state support team of CFPS is housed at the Colorado Department of Public Health and Environment, and we work to coordinate local child death review teams, and these multidisciplinary teams conduct death reviews for infants, children, and youth under age 18 who die in Colorado by any of the causes that you see listed on the slide, which are largely due to injury and violence. As a system, we're responsible for reviewing all deaths by motor vehicle and other transportation, sudden unexpected infant deaths or SUID, which are mostly those sleep-related infant deaths, child maltreatment, suicide, homicide, overdose and poisoning, unintentional injuries such as fires, drowning and falls, and other deaths that may be due to undetermined causes. And the final arm of our system is our state review team, which takes the data and prevention recommendations that are entered by the local teams during case reviews to then develop overarching recommendations to prevent child deaths that we present annually to the Colorado legislature in July. As a system, we really strive to incorporate equity into every facet of our child death review process. If you're unfamiliar with child death review, it looks different in every state, but here in Colorado, as I mentioned, we have review teams at the local level. So those can be counties and also some regional teams that come together. So this equitable process really starts with recruiting and convening diverse and inclusive review teams where there's shared power among team members. And having these diverse and inclusive teams really encourages prevention discussions during the review that are focused on systems level changes that lead to more equitable findings. And having this process, again, leads to prevention recommendations that prioritize that community voice and considers potential unintended consequences of the recommendations that we make. And in my opinion, one critical factor that keeps this equitable process running as best as possible is to always advocate for equity through disparity data. And one of the major ways to do that is by thoughtfully framing disparity data through the context of inequitable systems and policies, which leads me into a few different lenses that I want to provide you all for how to view the data. Before moving any further, I want to make sure we're all on the same page when it comes to terminology. So for purposes of this presentation, inequities are defined as systemic, avoidable, and unjust factors that prevent people from reaching their highest level of health. Disparities are differences in health outcomes between people that are related to social or demographic factors such as race, ethnicity, gender, sexual orientation, or geographic region. And by measuring disparities over time, we can measure our progress toward achieving equity for all people. It's so important to keep equity front and center in child fatality prevention work because there are disparities observed for almost every cause of death that we review. Among other areas, we observe disparities by race and ethnicity, by place of residence, such as in an urban or rural setting, and by sexual orientation and gender identity. We try to always remind partners across the state and the country about the social, economic, and environmental inequities that contribute to families losing children by injury and violence. And that when we're reviewing disparity data, we never lose sight of these systemic and unjust factors that perpetuate those disparities. And even when there are limitations in our data because of how we collect the data, which there definitely are limitations, and I think that can be relatable really to any data system, we always strive to provide additional context and research about how inequities impact child deaths, which is a key component of our work and something that I'll provide a lot of during the presentation today. And when I share disparity data, The additional context that we provide about systems and policies that impact those disparities is what we call an equity lens, and I'm sure you've heard that phrase before. But here's another poll. So to understand a little bit about where you're coming from, do you share disparity data in your own work using an equity lens? Let me see if I can launch this. Great. You should have a poll in front of you now. We're about halfway there. I'll wait another 30 seconds or so. Okay. So a couple of folks said, yes, I do it every time. The majority of you all said, yes, I use an equity lens, but only sometimes. And also a handful of people said, I'm not sure, or I've only seen other people do this. So thank you for answering that question. It's really my goal with the presentation today to provide everyone tools and ideas for how you might continue using an equity lens, or how you might start using an equity framework when you share and talk about your own data. So in addition to an equity lens, this other second lens I like to provide before presenting, especially child death data, is through this quote: "Statistics are human beings with the tears wiped away." Today, I'm going to be sharing some data related to infants, children, and youth who have died in Colorado due to injury and violence. And it's so important to remember the children represented by these numbers and the families and communities who have suffered such devastating losses. I also like to note for any audience that although there are some statistically significant disparities in the upcoming slides, there are also other important patterns that inform our prevention work that are not statistically significant. And I say this because in public health and as epidemiologists, we can get so easily bogged down in only looking at differences that are statistically significant without looking at other important stories that the data might tell us. So some of the data that I'll share today are not statistically significant, but are still crucial patterns to consider for prevention. And they often do mirror significant patterns that are happening across the country at a national level. So like I said before, the disparities in child deaths that I'll talk about today lie in three main categories: geography, race and ethnicity, and sexual orientation and gender identity. I'm going to spend several minutes in each of these areas outlining the inequities experienced and how they could perpetuate disparities in different types of child deaths. And I'll start by looking at the geographic disparities. So geographic disparities in child deaths often result from the social conditions that are facilitated by structural inequities experienced by rural and frontier communities. The way that our program looks at geographic differences is by using county designations that are applied by our Colorado Rural Health Center. And as you see in the green box on the slide, all counties that are not designated as parts of metropolitan areas are considered rural, and frontier counties are further classified as those with a population density of 6 or fewer people per square mile. So on this map, the light blue counties are rural and the darker blue are considered frontier. It's always striking to me when I look at this map that 47 of Colorado's 64 counties, or about 73% of the state, are designated as rural or frontier. It's also worth noting that these overall county designations are limited in that they don't account for some geographic nuances that are experienced by a few counties where there might be a populous urban center, and also broad rural areas. So that's also just worth mentioning as well. But these rural and frontier communities experience several inequities that contribute to child deaths and other health outcomes. One such inequity is the geographic and social isolation experienced by rural communities. Rural counties usually encompass large geographic areas, which results in broad expanses of land with small population sizes. Living in a rural area can definitely be isolating, where many folks are self-reliant for survival. This can decrease a person's sense of connectedness and support, which we know through our work is very important protective factor for several forms of injury and violence, including suicide and child maltreatment. With less face-to-face contact and connection, people living in rural areas may experience greater feelings of loneliness, depression, and suicidality. Another important factor is limited access to healthcare, such as mental and behavioral health services. We know that when healthcare is readily available and accessible to people, it reduces the risk of outcomes such as suicide. For example, the lack of behavioral health care is mostly due to having too few qualified clinicians and long travel times to any healthcare facility. It's even been shown that many folks living in rural communities are less likely to even have mental health benefits through their health insurance. Using national data from the Department of Health and Human Services, we see that there are about 6,000 areas that have a shortage of mental health care professionals, and about 70% of those are rural areas. Where there is a shortage, primary care physicians are often called on for mental health care, even though those doctors often report not feeling prepared to treat mental illness. You'll see more data pop-ups like this one throughout the presentation today. As I mentioned earlier, our system currently collects fairly limited data about the stressors that are experienced by young people, families, and communities in Colorado. So whenever possible, we strive to highlight other data sources that can supplement and better contextualize our own data. So using this additional research and supplemental data, we better understand potential root causes of some of our own statistics. For example, data from our system shows that 38.2% of children and youth who died by suicide in Colorado and lived in a rural or frontier county had received prior mental health services, compared to 53.3% of those living in an urban county. Going further into limited access to care, rural and frontier counties also experience a lack of level 1 trauma centers and longer response times by emergency medical services, which might impact emergency response to trauma incidents, including motor vehicle crashes and drownings. Isolation and lack of healthcare is amplified by increased stigma experienced by rural communities related to seeking help and mental health. Even when mental health services might be available to people, many living in rural areas report not wanting to seek help because of the stigma and lack of anonymity when accessing services in a rural setting. Instead, when people feel distressed, many may attempt to help themselves alone or seek informal support from family and faith communities. This sense of independence has been found to sometimes result in feelings of shame around mental illness, which is a sense that can often run across generations within families. There are also other social norms that may contribute to disparities in rural areas. One example are the social norms related to safety belt use in vehicles. National studies show that seatbelt use is lowest in rural counties, and that the number of unrestrained people in a vehicle at the time of a fatal crash is highest in the most rural areas of the country. Rural and frontier communities also have greater access to firearms as a lethal means, since owning and using firearms is much more common and is a large part of the culture. Rural residents often grow up around firearms, have them in their homes, and use them for protection, hunting, agriculture, and recreation. Research has also found that rural families have more firearms in the home, with 75% of rural firearm owners having more than one firearm, compared with 48% of urban firearm owners. Living in a home with firearms that are stored unlocked and loaded increases the risk of suicide, and having more firearms in the home is a potential barrier to safety since you have more weapons that need to be stored securely. And then lastly, rural communities are often confronted with a lack of nearby services that support families, which can be made even more difficult, as I mentioned, in combination with limited transportation options and long travel distances to access services. One example is that rural areas often have limited access to childcare, and caregiver stress is really high when people are worried about having unstable childcare and unreliable emergency childcare that is near their home. But we know that when having stable, affordable childcare, it helps to prevent outcomes like child maltreatment. Together, all of those inequities that I just mentioned contribute to higher rates of death in rural and frontier counties for many of our leading causes of death. We see that the data on this slide from 2014 to 2018, infants, children, and youth residing in frontier counties in Colorado are 3.9 times more likely to die by motor vehicle crashes, 2.9 times more likely to die by firearm, and 2.4 times more likely to die by unintentional drowning when compared with those living in an urban county. And you can see that there are similar disparities for suicide, child maltreatment, and sudden unexpected infant death. When thinking about prevention, it's so important to consider that by changing the policies and systems that create and perpetuate the inequities that I talked about, we can eliminate these disparities and achieve equity for all Coloradans. One important thing to note is that we're still learning and we're still improving how we share and frame our disparity data. So this last spring is actually the first time that we formally shared geographic disparities and spoke about these specific inequities. Our rural partners really felt that they were seen and heard, but by no means is the information that I just shared an exhaustive list. So I'm always open to new ideas and feedback. Please do let me know if there's anything missing throughout the presentation today that you feel like there's missing and I should be addressing alongside our data. So with that, do you have any questions about anything that I've talked about so far?
Sasha, this isn't a question, but a few of us are seeing a weird, some black bars moving across the screen. So can you try unsharing your screen and resharing it to see if that fixes the problem?
Sure, that has happened before, but it's pretty hit or miss. So let me try. Is that any better?
It's still there for me, but
is
I'm not
it
sure.
Like blocking a lot of info?
Mostly just the very top of the slide.
Okay.
So
I'm not sure what the solution is to that.
me neither.
Okay.
So we can just keep going then.
Okay. Well, I'll pause for one more minute if folks have any questions. Okay, well, there will be more time for questions. Definitely let me know. But next, I'll talk about how we frame disparities by race and ethnicity. Racial and ethnic disparities in child deaths result from the conditions facilitated by racism and discrimination. For example, disparities in our outcomes for American Indian or Alaska Native populations often stems from the loss of population, land, language, and tradition that was endured by these indigenous communities. Historical trauma originates in colonization, which was the brutal and forcible removal of indigenous American Indian or Alaska Native people from their lands in the United States and Canada, resulting in population decline and subjugation of indigenous people. Following colonization, indigenous children were forcibly removed from their families and taken to boarding schools that stripped them of their culture. Children were mandated to attend these schools where they were forbidden to practice their culture through aspects such as hairstyle, clothing, and language. Native Hawaiian or Pacific Islander populations also endured colonization by the United States and experienced trauma that includes the overthrow of the Hawaiian monarchy and continued contamination of their lands and people by nuclear testing conducted by the US military. The trauma and legacy of colonization accumulates across generations within families into current day, leading to substantial socioeconomic and health disparities, including increased infant mortality, suicidality, and child maltreatment. Additionally, people of color who report experiencing unfair treatment, racism, and discrimination across the lifespan experience poor mental and physical health. For example, there's a growing body of research showing that the chronic stress created by everyday experiences of racism and discrimination contribute to allostatic load, or wear and tear on the body. These biological processes, which are attributed to chronic stress, are associated with health effects such as negative birth outcomes, which influence the risk of sudden unexpected infant death. Experiencing racism and discrimination is also associated with increased drug and alcohol use, which may be a coping mechanism for the chronic high levels of stress endured from everyday experiences of racism. Racial residential segregation is another form of structural racism, which can lead to racial and ethnic disparities in child deaths. Racial segregation is largely driven by discriminatory policies such as redlining that create unjust geographic divisions among racial and ethnic groups. Redlining occurred when the Federal Housing Administration drew up maps of major cities and marked red entire neighborhoods where people of color lived. Redlining prevented Black families from owning homes, as mortgage lenders would look at the redlined maps and refuse to lend money for Black families to move into majority white neighborhoods. On the slide is a redlined map of Denver in 1934, showing how neighborhoods like Five Points and Globeville were highlighted red and systematically segregated. This also happened in other towns in Colorado, like Pueblo. The effects that racial segregation has on communities include concentrated neighborhood poverty, increased exposure to environmental stressors such as air pollutants, and systematic advertising by alcohol and tobacco companies. As I mentioned before, increased substance use may be a means of coping with stress, but to compound that, communities of color living in segregated neighborhoods are exposed to a higher level of tobacco and alcohol marketing. Segregated neighborhoods also have limited access to health services and increased housing and food insecurity. As just one example, the Colorado Behavioral Risk Factor Surveillance System, or BRFSS, shows that 45.7% of American Indian or Alaska Native, 39.8% of Hispanic, and 36.2% of Black Coloradans are food insecure, meaning that they lack reliable access to affordable, nutritious, and possibly culturally traditional food, compared to 19.2% of non-Hispanic white Coloradans. Part of this may be due to some supermarkets that could provide access to affordable quality food, not wanting to build stores in low-income urban neighborhoods. Some supermarkets even go so far as to closing existing stores in order to relocate them to white suburbs. These are examples of how community inequities contribute to disparities in child deaths among communities of color, including infant mortality. The history of racial residential segregation in our country also helps explain why the disparity in drowning among Black children and youth exists. Racial residential segregation is very closely tied with the social history of swimming pools in the US. The book cover that you see on your screen, Contested Waters, is a resource to learn a lot more about this history, outlining how the inequitable construction of swimming pools, eventual racial segregation of city pools, and the subsequent white flight to private swim clubs in the suburbs have culminated in a higher risk of unintentional drowning among Black young people. As I also mentioned, racial segregation concentrates poverty in certain areas and isolates residents from key resources. Families of color inequitably and systematically experience poverty in the United States, an established risk factor for outcomes like child maltreatment, infant mortality, and suicide. Data from the Census Bureau, as you can see on the screen, shows that 18.7% of American Indian or Alaska Native, 18% of Black, and 14.5% of Hispanic Coloradans live below the poverty level, compared to 7.5% of non-Hispanic white Coloradans. In addition, poverty is continually perpetuated by social policies that maintain segregation. For example, research suggests that even though motor vehicle deaths have actually decreased nationally, the decreases have largely benefited more affluent and well-educated communities where people, as we know, are more likely to own expensive vehicles with advanced safety features. Physical and built environment factors also contribute to disparities in child deaths. For example, the Federal Aid Highway Act of 1956 allocated billions of dollars to interstate highway construction, which delivered the safest and most modern way to travel at the time. Unfortunately, the government chose to build these highways through or near urban communities that were racially and ethnically segregated, resulting in even further disinvestment in neighborhood infrastructure. It lowered property values, further increased poverty, decreased access to quality education, and overall provided more dangerous environments for driving and walking. Even to this day, investments in road safety, such as street maintenance, crosswalks, and street lights, are less likely to occur in segregated and low-income communities. In regards to child maltreatment, there's also quite a bit of research about the overrepresentation of children of color in the child welfare system. Studies have found that Black children are more likely to be the subject of child maltreatment reports and substantiations than white children. Research poses a few reasons why this overrepresentation exists, including how poverty can amplify a family's exposure to the social service system and increase exposure to mandatory reporters, which is something called visibility or exposure bias. There's also potential bias and discrimination within the child welfare and social service system, urging a need for training and cultural competency. It also bears repeating that since colonization, Indigenous children have continually been removed from their homes. American Indian and Alaska Native children have been systematically placed into out-of-home care compared to white children in the child welfare system. And from the perspective of Indian child welfare, this is happening because policies in the US were specifically designed to remove Indigenous children from their homes in an effort to perpetually undermine Indigenous nations. There are also some cultural differences in child safety practices that highlight the lack of culturally relevant prevention strategies. For example, there are cultural differences in child restraint use, such as seatbelts and car seats, which may contribute to disparities in motor vehicle deaths. Research suggests that Hispanic caregivers may be less likely to use safety restraints in certain situations, including being on a short drive or in a rush, not having enough restraints in the car, and if someone was holding the infant or child. There are also differences in safe sleep practices for infants across racial and ethnic groups, which may contribute to the disparities in sudden unexpected infant death. Research has found that infant sleep decisions are often driven by the caregiver's culture and perceptions of what makes the infant comfortable and safe. These couple of examples really, again, highlight the importance of collaborating with communities of color, using a multi-generational approach on the best methods to increase child safety practices. Together, the inequities I just spoke about contribute to disparities in the rates of infant, child, and youth deaths by race and ethnicity here in Colorado. For instance, non-Hispanic Black infants, children, and youth are 12.3 times more likely to die by homicide, 4 times more likely to die by unintentional drowning, and 3.5 times more likely to die by child maltreatment when compared with non-Hispanic white infants, children, and youth. American Indian or Alaska Native infants, children, and youth are 4.5 times more likely to die by child maltreatment and 2.9 times more likely to die by sudden unexpected infant death when compared with non-Hispanic white children. And by presenting the disparity data in the context of all of the inequities that I described, we're emphasizing the social responsibility of these deaths rather than inadvertently perpetuating negative stereotypes by sharing the statistics without any framing at all. We can focus prevention efforts on the systems and policies that create and perpetuate the inequities and reduce disparities. Okay, that was a lot of really important information, but what questions do you have at this point? I'll just pause for a moment. And again, feel free to unmute yourself or put your questions in the chat box. Okay, well, we'll have another time for questions at the end. But finally, I'm going to talk about disparities by sexual orientation and gender identity. Just so that we're all on the same page, I want to go over some definitions. So, sexual orientation is a person's physical, romantic, and emotional attraction to other people. This attraction can be to people of the same sex or gender, opposite sex or gender, both sexes, more than one gender, or no gender. Examples of sexual orientations are heterosexual, lesbian, gay, and bisexual, among others. Gender identity is a person's innate, deeply felt sense of identifying as male, female, or non-binary, regardless of the sex that they were assigned at birth. Cisgender means someone's gender identity is the same as their sex assigned at birth, and transgender refers to a gender identity that is different from someone's sex assigned at birth. It's important to mention that sexual orientation and gender identity are spectrums. Sexuality and gender are fluid and can change over time. Together, LGBTQ+ is an acronym that encompasses many diverse sexualities and genders. It stands for lesbian, gay, bisexual, transgender, queer, questioning, where the plus represents other sexualities, sexes, and genders that are not included in those few letters, such as intersex, asexual, pansexual, agender, bigender, genderqueer, and many more. So I encourage you, if you've never heard of those terms, to Google, find out what they are. LGBTQ+ is a huge array of different identities. There are disparities in health outcomes by sexual orientation and gender identity that result from the sexual context facilitated by discrimination, stigma, and bias. Although all young people might experience harassment and bullying, those who identify as or are even perceived to be LGBTQ+ are exposed to additional harm. Research shows that experiences of harassment related to sexual orientation and gender identity are extremely common for LGBTQ+ youth. Just a couple of weeks ago, GLSEN released their 2019 National School Climate Survey of middle and high school LGBTQ youth. The survey found that a striking 86.3% of LGBTQ students experienced some form of harassment or assault based on personal characteristics. Discrimination experienced by LGBTQ+ youth is driven by the heterosexual and cisgender norms that dominate our culture and systems. The social context results in LGBTQ+ people experiencing discrimination, stigma, and bias, including rejection from family, friends, and community, as well as limited access to LGBTQ+ informed healthcare. This impacts health for LGBTQ+ people across the lifespan, including increased suicidality, substance use, and risky driving behaviors. We do know that having LGBTQ+ inclusive curricula at school and school policies that explicitly prohibit bullying and harassment based on someone's sexual orientation and gender identity are protective for young people for outcomes like suicidal ideation and attempts. However, a national 2011 survey found that only 1 in 10 school districts have inclusive policies that specifically enumerate protections for both sexual orientation and gender identity. And that new GLSEN report that I mentioned that was released last month found that 8 years later, in 2019, that number had not changed much, with only 13.5% of students reporting that their school had inclusive policies. In fact, nearly 60% of LGBTQ middle and high school students reported personally experiencing discriminatory policies or practices related to their sexual orientation or gender identity while at school. The survey also found that only 8.2% of students had received LGBTQ inclusive sex education. These findings highlight several critical areas where I know we can focus prevention efforts. As some folks may know, collecting information about sexual orientation and gender identity after a young person has died is incredibly difficult, and that results in poor data quality on LGBTQ+ people across all systems that collect mortality data. However, not having that data to share from our own system doesn't mean we should ignore the disparities that we know exist and contribute to deaths. There are other data sources in Colorado to provide information about health outcomes by sexual orientation and gender identity. In Colorado, we use the Healthy Kids Colorado survey to talk about these disparities specifically for young people. 2017 data from the Healthy Kids Colorado survey shows that lesbian, gay, bisexual youth are 3.9 times more likely to have attempted suicide in the past year when compared to heterosexual youth. And transgender youth are 5.2 times more likely to have attempted suicide in the past year compared to cisgender youth. Another example is seen with substance misuse and risky driving disparities. Lesbian, gay, and bisexual youth are 1.9 times more likely to have used a prescription drug in the past month without a prescription when compared to heterosexual youth. And transgender youth are 7.4 times more likely to have driven a vehicle when they've been drinking alcohol in the past month compared to cisgender youth. Again, this disparity data shines a light on how we can focus prevention efforts on the systems and policies that we know can support LGBTQ+ youth and their communities. So by sharing disparity data with a comprehensive equity lens, we're able to move towards more equitable prevention strategies using a shared risk and protective factor approach. Stated more clearly, sharing thoughtfully framed data in the way I just talked about helps us as a system, as well as our external partners, understand that by changing the policies and systems that create and perpetuate inequities, we can reduce the number of child deaths that occur in Colorado and eliminate disparities. And this approach can apply to so many programs and outcomes, including those that you all work on. Insert your own program and outcome into this statement and think about how you can move upstream to change how policies and systems work to help people instead of harm them, addressing inequities and eliminating disparities. Some examples are the prevention recommendations that we make to our legislature, as I mentioned, every July. So the upstream strategies that you see on the slide are the ones that we prioritized this year. For example, I spoke earlier about limited access to healthcare and family support services in rural areas. However, prevention strategies like increasing telehealth services and supporting policies that expand access to stable childcare can decrease the geographic disparities in outcomes like suicide and child maltreatment. Additionally, prevention strategies like paid family leave, which allows people paid time off from work to care for themselves and their families, is a known strategy to decrease racial and ethnic disparities and maternal and infant health. Paid family leave supports families' financial stability and provides protection against factors that increase the likelihood of children dying of injury and violence. Paid family leave also supports safe sleep factors such as breastfeeding, which has significant health benefits for both moms and babies, including protection against sudden and unexpected infant death and child maltreatment. Paid family leave as one success story is a recommendation that we've had in our report for several years. And just this last election cycle, Colorado passed paid family leave through a ballot measure. So this is one great success that we've had, and we're hoping to improve how these other recommendations move along. One last example is by increasing the diversity of the behavioral healthcare workforce and requiring annual mental health screenings for young people, having more healthcare providers of color and of diverse sexual orientations and gender identities would better represent the diversity of the state and better meet the needs of patients. That list is not a comprehensive list, though. There are so many other prevention opportunities that would address inequities and impact disparities. For example, safe firearms storage, addressing food insecurity, making sure that there's access to equitable public resources such as parks, safe roads, and streetlights. We need to do more to promote LGBTQ inclusive curriculum at school, including sexual education, and make sure school districts are providing protections for sexual orientation and gender identity in their anti-harassment and anti-bullying policies, and going even further to make sure that such inclusive policies are being enforced. A lot of what I just presented to you is included in a report that we recently released called The Role of Policies and Systems in Child Deaths in Colorado. You can access it directly from the link on the slide, which I'll also put in the chat. But overall, I hope that by listening to this session, you've been able to identify a few ways that you can use the information that I just shared in your own work. Which brings me to my very last poll question. When you go back to your work, how do you plan to use what you learned today? Okay, and you can choose more than one of these responses. Just give a few more seconds. Also, I'm curious if you selected other, feel free to drop that into the chat box. Okay, so a lot of folks I'm so excited to see said that they'll improve how they frame data with an equity lens. They'll utilize disparity data to guide their prevention efforts. And a lot of folks said that they will also research how inequities affect the communities that they serve. So thank you all so much. So I know that if we practice this, it'll impact our overall equitable approach to injury and violence prevention. And it's something that I'm really passionate about. And I hope that as you explore how you do this in your own work, it'll become something that you're passionate about as well. I can definitely take any questions. I see one in the chat from Catherine. Something that comes up a lot when talking about health equity and data is the need to consider data that are missing and are not being collected. What tips do you have for identifying holes in data collection? That's a great point. So as I mentioned a few times today, we certainly have big limitations in our own data system, which is a data tool that is maintained at the national level. And every year we're slowly making improvements to the data tool. Recently, a section was added to our child fatality tool, allowing us to select if certain life stressors are being experienced by a young person or their community or their family, such as racism, discrimination, housing instability, food insecurity. So we're looking forward to see how that data shapes up when we have it available. But one thing that is tried and true is to make sure that you're using other data tools like the pop-ups that came up on the slides today from the Census Bureau or behavioral risk factor surveillance system or the youth risk behavior system is just all such rich data that you can use to supplement your own to understand the stressors that are being experienced. So I think that's kind of how we as a system have identified the gaps in our data, is that when we looked at disparities, like I shared, by race and ethnicity, and seeing how the systems and policies impact those disparities, we realized that we weren't collecting any information on those stressors. And that caused us to be like, we need to supplement our data with everything else that's out there, either at the national level or at the state level if we can find it. I hope that answered your question. And also, I want to open it up for other folks. Great question, Mina. How do you work with counties to ensure that the child death review data is being entered and is being entered consistently throughout the state? So that's a great question. In addition to myself as the epidemiologist, I have wonderful colleagues who work individually with all of our local review teams at the county level to make sure that we're providing technical assistance and as much guidance as possible to make sure that the data is being collected in a standardized way. We provide our own state level guidance tools, and there's also a data dictionary that we try to encourage folks to adhere to as well. So we provide that technical assistance up front, and we also conduct quality assurance checks on every single case to make sure that data is consistent. But as with a lot of other systems, we try our best, and some teams might interpret questions a little bit differently, and I think that's just the nature of surveillance sometimes. That's a great point, Lauren. We are doing as much as we can at Colorado Department of Public Health to make sure that we are using system-centered language as well. If it's okay, I'm going to stop sharing my screen so that I can pull down a great article that we have been using a lot lately to address that. One second. Okay, so here is an article / blog post that we have been using as a team to really audit all of our products that we publish to make sure that we're using system-centered language, just as you said, to make sure we're avoiding the words at risk, vulnerable, disproportionately, knowing that all of these systems and policies have historically excluded different populations, and that we're sharing this data in a way that really puts the onus on the systems. So I think that article is a good resource, of course. Well, there's 5 minutes left. If you have any other questions, definitely put them in here, but I'll also put in my email address. Feel free to reach out for any reason at all. I'd love to hear from anyone. And I'll pass it back to you, Rachel.
All right, thank you so much, Sasha. That was really awesome and really informative. I am putting a link in the chat for the evaluation survey for today's learning opportunity. Please fill that out for us. And I'll also email it out in a couple of days when I email out the recording of this session. And I guess we can give you all 4 minutes back into your Monday. So thanks again, everybody, for joining us. And thanks again, Sasha, for the awesome presentation. Have a great rest of your day, everyone.